Good evening, everyone. Thank you so much for joining us in the Prostate Conditions Education Council educational series. We want to give you a reminder that you're welcome to submit questions. And tonight we are joined by Brittany, who is going to be educating us on genetic testing and prostate cancer. Brittany graduated from Northwestern University's graduate program in genetic counseling in 2018 and received her PhD in genetics from the University of Rochester in 2016. She currently works as a genetic counselor in the urology department at Northwestern and is part of the cancer genetics program, where she focuses on prostate, GU, and GI related cancers. She is also a lead genetic counselor for Northwestern's early detection in genetics for BRCA in men. The goal of this program is to provide coordinated screening for unaffected men with BRCA mutations, which you'll learn more about later today. Brittany, I'm going to turn it over to you to begin.
All right, excellent. Thank you, Lindsay. Once again, welcome everyone to this talk about genetic testing and prostate cancer. And once again, my name is Brittany Simonak. I'm a genetic counselor located in the urology department over at Northwestern in Chicago. And I just wanted to give some really quick disclosures. I am a consultant for Clovis Oncology as well as Euro GPO, and I've received honorarium for presentations with Invitae, as well as being an advisory board member for what's called the Target study. So I just wanted to start pretty broad because I'm not really sure in terms of everybody's background who's joining us today. So with prostate cancer specifically, this is something that affects approximately 12% of men over their lifetime. So we're looking at between 1 in 8 to 9 men that are being diagnosed with prostate cancer. So unfortunately, this is a fairly common cancer that we see affecting men here in the US. And if we take kind of a closer dive and looking at prostate cancer and compared to some of the other cancers that affect men as well as women, prostate cancer is one of the top cancers that we see that is estimated to have new diagnoses in 2020, leading about 20% of new diagnoses for men. And we see that out of the estimated cancer deaths, cancer-related deaths, prostate cancer is about 10% there. So not as high as what we see for lung and esophageal type of cancers, but certainly it's high in the list of things here. But just kind of as a quick comparison, when we think of prostate cancer being fairly common for men, I like to tell my patients that this is something that's just as common as breast cancer for women. So these are both very prominent cancers in our population, and certainly something that we think about when it comes to the genetic side of things, which is part of the whole purpose of today's talk. And I just wanted to give people a little bit of background when it comes to the ages that we're typically seeing people being diagnosed with prostate cancer. So usually the median age is going to be about 66. So usually between 65 and 75 or 74 is when we see people being diagnosed. But we do see a fairly significant number of people in their 50s to 60s that are also being diagnosed. So this isn't necessarily just a cancer that affects people at significantly older ages, even though we can see age being a factor for diagnosis. And that leads me right into some of the risk factors. So age is definitely one of the leading factors that we see for prostate cancer. As for other cancers, as we get older, that risk for developing cancer is going to increase. But with prostate cancer, there is definitely a race and ethnicity component that we can see, with African-American men being at significantly increased risk to develop prostate cancer, as we would see for their Caucasian counterparts. And then also, if there's a family history of prostate cancer, we know that that in and of itself is going to increase the risk for close relatives to be affected. So talking about a 12% possibility for somebody to develop prostate cancer over their lifetime. If somebody has a close relative, we're looking at potentially, 22, 24% risk for somebody to develop prostate cancer. There's a lot of discussion about other risk factors that we can see. They're not as clearly defined. Some of them potentially have more of an impact on prognosis, with already having a prostate cancer diagnosis, but there's things out there concerning things like diet or obesity, smoking, certainly different chemical exposures, as well as histories of things like prostatitis or infections of the prostate. But it's not, like I mentioned, as clearly defined as what we see for these top three here that I mentioned. And just, to make sure that we're also all on the same page, is that prostate cancer is, even though it's common, is a very individual disease. It's not going to be the same experience for every person that's diagnosed. And there's a lot of individual considerations to take into account. So everybody doesn't necessarily have the same path to diagnosis. Not everybody has the same discussions with their doctors or wants to make the same decisions about disease management or treatment options. So things are going to be different for different people depending on, their values, what their expectations are, and kind of what their goals are. And all aspects of these decision-making processes are going to be different because everyone is going to be different when it comes to their priorities for that. And there are a number of challenges when we think about prostate cancer. So as we just talked about, age is a factor that we can see for that. So we're seeing an increased number of cases as our population overall is getting older. And just like we see for any other cancer, it could be very expensive to treat. But there can be considerations when we're actually screening for prostate cancer. So doing things like PSAs, are we doing things like MRIs or doing prostate biopsies? And then the exact cause of prostate cancer really isn't known, just like with all the other cancers. Unfortunately, we don't necessarily know kind of what the single driving factor is that causes people to develop cancer. And as of right now, there's not really any preventative options. I don't think any men are going to be lining up necessarily to have a preventative prostatectomy because that's just not going to be a reasonable expectation when it comes to preventing something like prostate cancer from happening. And then their treatment decisions are going to be very complex and multifaceted. So there's different stages of disease, there's different risk categories that we talk about, there's different management recommendations or options for individuals based on those different factors. So there's a lot of different components that can go into this, especially if you're talking with somebody who's a urologist versus somebody who might be an oncologist, might have different recommendations for things. And so with some of the information about prostate cancer kind of discussed, I wanted to, before we dive into more of the specifics about genetic testing in prostate cancer, to just give everybody a little bit of an introduction to genetics, once again, because I'm not sure how much background everybody's coming in with, so I want to make sure that we're all kind of starting on the same playing field. So just as a very brief reminder, kind of in genetics 101, so in all of the cells of our body, we're going to have our chromosomes. So we all have 23 pairs of chromosomes that are essentially continuous strands of our DNA that are all packed together into the chromosome structure. But if we start pulling out and looking at those strands of DNA, we can see kind of this double helix formation, and the DNA itself is going to be made up of different base pairs. And there's certain segments of DNA that are considered genes. So these are what encode proteins and have all of the instructions for our body to kind of grow and develop and do all of the things that it's supposed to do. And for some context, so we have about 20,000 genes total, but that only makes up about 1% of all of our genetic information. So there's still a lot that we don't understand about what some of this other DNA is actually doing. But when we're thinking about genetic testing, we're thinking about not only those 20,000 genes, but a very small subset of those 20,000 genes that are going to be associated with things like hereditary cancer, which we'll come back to later. And I wanted to give everybody a little bit of a background in terms of terminology. So there's going to be a couple different words that will come up during today's presentation. So things like a variation or a variant. So this is going to be a change in our genetic code that doesn't necessarily match what we would call our reference sequence. So this is kind of what we would expect based on our understanding of what the composition or spelling order of our genes is supposed to be. It doesn't necessarily mean that it's harmful. We all have genetic changes in our DNA, but they don't all cause disease. So that's why this is still kind of more of a broad term. But when we have something that's referred to as a mutation, this is going to be a variation that is actually going to compromise that gene's function. And because that gene isn't working properly anymore, we can see alterations in the protein that's being produced. So what's actually supposed to be functioning and doing its role in the body isn't able to do that correctly anymore. And then when we have something that's referred to as somatic, this means that this is a genetic variation or change that's occurring only in our tumor. So we think about this as being something that's acquired, so something that has developed over your lifetime. But if we look at something that's called germline, this is going to be something that is inherited. So a genetic variation that you were born with that's going to be present in all of the cells of your body. So to take a closer look at some of the information on somatic versus germline. So once again, these somatic mutations are going to be changes that are interrupting protein function that have happened over time. And these are confined to specific organs. I put germline tissues here because these aren't going to be present in your egg or sperm cells. So these aren't going to be passed on to children. And these are typically associated with sporadic cancers. So with these mutations, these are going to help drive cancer development. And we'll kind of come back to that concept in a couple slides here. But if we look at a germline mutation, once again, this is something that you would have been born with that was inherited from one of your parents, either mom or dad, that's going to be present in all of the cells of your body, including those egg or sperm cells. And as a result, this potentially can be passed on to children, which is how we see some of these hereditary syndromes being passed down in the family, which once again, we'll come back to in a couple slides. So if we take a closer look at this somatic or sporadic cancer development, so we have a group of our normal cells, and in one of those cells, we have, or in all of our cells, we have 2 copies of all of our genes. And these 2 genes are functioning normally, and over time, at one point, one of those copies has a gene mutation that occurs. And this can happen due to a number of different things. Age, like we've talked about, is definitely a factor. Our ability to kind of maintain our DNA as we get older decreases. So sometimes we can have errors that are introduced that are just because our processes are not as refined as they used to be when we were younger. But things like smoking or radiation, or if somebody's had different chemical exposures over their lifetime, we know that can affect these mutations. And then we can see maybe the other copy of that gene being interrupted. Maybe there's another mutation that happens. And depending on what gene this is happening in, what the function of that protein might be, then these cells might start to grow out of control. And then over time, these mutated cells continue to spread, and then we can have a tumor that's developing. So with this, we're starting with normal cells that are acquiring mutations over time. But if we look at hereditary cancer, all of these cells are starting with a change in one of these genes already. So once again, you're born with this. So you already have one copy of a gene that's not functioning properly. And then once again, just like we saw with the sporadic cancer, is there can be things that we're exposed to, aging, smoking, that can affect whether or not there's other gene mutations that happen. And so there might be a copy, the second copy that has a gene mutation. And then once again, we see the same pattern where there's out of control growth of some of these cells, and then we can see a tumor developing. So we think of this as individuals being predisposed to developing cancer because they're essentially already one step down the line, being a little bit closer to developing a cancer, but there's still other things that need to happen in order for that tumor to develop. And to look at that a little bit more closely in thinking about sporadic versus hereditary cancers, is that all cancers ultimately are due to genetic changes, but not all of these cancers are actually going to be due to hereditary changes. So if we look at this pie graph here, about 70% of all cancers that we see are going to fall into a sporadic category. These are ones that occur by random chance. They may be related to different environmental factors, but we think of this as more general population cancer risk. And then there's familial forms of cancer that we can see. And this is definitely something that we can see with prostate cancer, is that we can see clusterings of prostate cancer diagnoses in a family, but there's not necessarily a single gene that we identify that's causing those cancers in that family. So we think it's multiple genetic factors that are shared between these close relatives that are all together kind of working to increase that risk for cancer to develop. That's kind of what we're thinking, in addition to there potentially being environmental factors, especially if a family is living in the same area. And so we know that there can be an increased risk for cancer, but it's not going to be as high as what we would see with some of the hereditary cancers necessarily. So it's fairly rare that we actually see that cancer is due to a hereditary cause. So about 5 to 10% of cancers. And once again, this is a genetic mutation that's present in the family, that's being passed down through the generations, that's predisposing people to develop cancer. But I just wanted to kind of emphasize, when we're thinking about hereditary forms of cancer and we're thinking about genetic testing for prostate cancer, the vast majority of people are going to end up being negative when it comes to testing. And so I always like to make sure that I'm setting patient expectations, even provider expectations, and that it's fairly rare that we're going to identify these, but when we do, it can be very meaningful for patients and their families, which we'll discuss more in depth. And I also just wanted to highlight kind of the inheritance and how this piece kind of works, is that these are changes that both men and women can carry. So we're seeing both versions here, either an affected father or an affected mother. And because we have 2 copies of all of our genes, we're only passing on one to each of our children. So we're passing on, mom is passing on one and dad is passing on one. So if there's a hereditary cancer syndrome in the family, we know that there's going to be a 50% chance for each child to be affected with that condition and a 50% chance for them not to be affected. So this is ultimately what's happening with these hereditary syndromes, is that this one copy is being passed down through the family. So to dive a little bit deeper into the genetic testing side of things, and more specifically look at prostate cancer. And I always like to start off this in that we've been doing genetic testing for hereditary cancer syndromes for quite a long time. It's been about 30 plus years. And in the introduction, they mentioned the BRCA genes. So we've known about these particular hereditary cancer genes, and we'll talk about them today, for a long time, and we've been testing for them for a long time. But it really isn't until more recently, back in 2018, that we've really started to develop an appreciation and introduce the idea of genetic testing from the prostate cancer side of things. I'd say within the past 5 to 10 years, we've really developed an appreciation for a hereditary component for prostate cancer that we haven't really, that hasn't really been appreciated for, other cancers we've been studying for a long time, but prostate cancer is still a little bit new to this. And there's still a lot that we need to learn. Because the testing is still relatively new, there's still a lot we don't understand about the cancer risks, and there's still not a fully established screening recommendations. And so to kind of think about, like I mentioned, with hereditary forms of cancer, looking generally at cancers, we say about 5 to 10% of cancer is going to be hereditary. If we zoom in to prostate cancer, if somebody has localized disease, we'd say that is probably about a 5% chance that we would identify one of these genetic or germline mutations. But there's been other studies that have come out that if we look at things like metastatic prostate cancer, it could be up to about 12%. Depending on what studies you look at, there can be more, there can be higher estimates that are given. I usually like to be a little bit more conservative because some of those studies are accounting for genes that are not actually associated with prostate cancer, but in that study, an individual tested positive for one of those genes. So it gets counted into the overall positive rate that was identified for that study. So I would say we're looking probably realistically around 12% of individuals that have a germline mutation that's actually associated with prostate cancer. And I wanted to give everyone some, like, a bird's eye view of, as a genetic counselor, what criteria are we using to evaluate for hereditary cancer syndromes? And I just wanted to start very general so that we can then apply that to prostate cancer. So I'm always looking for early ages of diagnosis. Depending on the cancer, we can have specific age cutoffs. So if somebody's diagnosed at a significantly earlier age than what we would typically see for that cancer, then that's always going to raise a flag for us. But we're also looking for whether or not there's multiple generations that are affected with cancer, and not just, any cancers. We're looking for cancers that can be related under a syndrome. So if we're seeing patterns of things like breast and ovarian cancer in a family, or things like colon, ovarian, or uterine, even things like melanoma and pancreatic. But then we're also looking for whether or not there's multiple primary cancers for an individual. So like we've kind of discussed, these cancers, because you're predisposed, because of this genetic change that you carry, there can be cancers diagnosed at earlier ages, but we can also see more than one developing. And certainly if somebody has bilateral disease, so both breasts are affected or both kidneys are affected, that also is going to raise a flag for us. We look for things like rare cancers, so ovarian cancer or male breast cancer. And then there's known ancestry groups that also have a higher incidence of certain hereditary cancer syndromes, like the Ashkenazi Jewish population. So that's something that I'm always going to be taking into account when I'm trying to assess for a hereditary cancer risk. So if we keep all of this information in mind and then apply that to what we're thinking about for prostate cancer, is that I'm looking for a personal history of metastatic or high risk disease. So does somebody fall into that category that we know that there's going to be a higher possibility of identifying a germline mutation? Was somebody diagnosed at an earlier age? So that also is going to come into play, especially if I see somebody that's diagnosed young and has metastatic disease. That's certainly going to be concerning for me. If there's multiple generations of prostate cancer in close relatives. So this is where it gets a little bit complicated in trying to weed out, is it the possibility that this prostate cancer history in the family could be due to familial risk, like we talked about, because these close relatives are affected? Or are we seeing these multiple generations of prostate cancer in the context of things like metastatic disease or earlier ages of diagnosis? But then we also look at, outside of prostate cancer, are there other related cancers that we know prostate cancer can be seen with? So things like breast, ovarian, and pancreatic, things like colon and uterine cancer. Does an individual have Ashkenazi Jewish ancestry? Because we know that for Jewish individuals, there's a higher incidence of BRCA mutations, so BRCA1 and BRCA2. For the Jewish population, we estimate that it's about 1 in 40 individuals will carry a change in one of those genes, versus 1 in 300 to maybe 1 in 500 for general population. So if somebody's Jewish and has a history of prostate cancer, that's certainly going to raise a flag for me. But then I also wanted to note that there's somatic tumor testing, which I'll kind of touch on a little bit later, that there can, because we're looking at the tumor, but also because this is, there's going to be the possibility of identifying germline mutations or concern for a germline mutation. We can have these findings come back on tumor testing that might need to be further evaluated. So if somebody has a BRCA mutation that comes back on their prostate tumor testing, then we would want to evaluate whether or not this is something specific that happened randomly for that tumor, or was this something that this individual was born with? So we're going to want to further assess that. And then to get into some of the genes that are actually associated with hereditary forms of prostate cancer. So as we've kind of been alluding to throughout this presentation, is that one of the biggest contributors is going to be BRCA, or the BRCA genes, specifically BRCA2. And this is associated with a syndrome called hereditary breast and ovarian cancer syndrome. It's a little bit of a misnomer because these are not the only cancers that we can see with this syndrome or with these genes. So because, as I mentioned earlier, we've been studying these for a long time, we've had a really good appreciation for the risks for things like breast and ovarian cancer for women that carry these changes. But we've come to really have a better understanding that men that carry changes in BRCA2 specifically have a risk for earlier onset and potentially more aggressive disease. We don't necessarily see that as much with BRCA1, but we know that the prostate cancer risk can be elevated for that as well. And so for many of my patients, they think of this as, oh, this is something that affects women and I don't need to worry about it. But this is definitely something that we can see affecting men. And we can also see other cancers, things like pancreatic cancer, male breast cancer, and melanoma happening with these genes. So there's other cancer risks that we would want to be on the lookout for. And then there are other genes that have been associated with this. So Lynch syndrome is another hereditary condition where the 5 genes below are all associated with. Lynch syndrome is more commonly associated with earlier onset colon cancer and uterine cancer, but there have been more studies that have been associating prostate cancer as part of that spectrum. So I always think about those when I'm thinking of evaluating family histories of prostate cancer. But then there's other genes that are listed here that are all associated with what we will call DNA damage repair. So, and just like with BRCA2, these are genes that when both copies are working properly, they're actually really good genes. They actually help protect our body from developing cancer because they're working to repair the damage that's happening to our DNA to prevent this kind of out of control growth that we can see for some of these tumors. And so when we have one copy of one of these genes that's not working properly, then we're kind of impairing that cell's ability to actually repair DNA. And this becomes relevant when we're going to talk about treatment options down the road. But I also wanted to mention another gene called HOXB13. This is probably one of the only genes that we know of that's really kind of only predominantly associated with prostate cancer. So we can see those patterns of prostate cancer in the family. And even though it might look like it's familial cancer, it's possible that we could be seeing that with something like HOXB13 as well. And so this is just kind of a flavor of some of the main genes that I'm thinking about when it comes to hereditary prostate cancer. But as I mentioned earlier, all of this is still really new. And so outside of the BRCA genes, I would say that we actually don't really have a clearly defined estimate or magnitude of risk when it comes to prostate cancer, and don't necessarily have clearly defined information about, is this going to affect the likelihood of somebody developing more aggressive disease versus just having an overall increased risk to develop prostate cancer. And then something that can also be really tricky is that we don't necessarily have clearly defined screening recommendations. So if we do identify one of these hereditary syndromes in the family, if there's an unaffected individual that tests positive, we don't necessarily have defined recommendations for when somebody should start prostate cancer screening. Outside of the BRCA genes, we don't really have that information for some of these other genes. So a lot of it comes back to those familial guidelines. If there's a family history of prostate cancer, we're making recommendations based on that and not necessarily if there's a gene in the family. And then there's still some genes that don't necessarily have clearly defined risks for other cancers. So I already mentioned HOXB13. There's some studies out there that say that there could be other cancers associated with this, but nothing that's really been well defined, as well as these other genes here are more preliminary evidence prostate cancer genes that we know that there's some association, but we don't really know really what the magnitude of risk is, what other cancers are, and we don't have recommendations for them. But this information, you know, the lack of information really that we have now doesn't mean that a couple of years down the road things won't look very different, because I usually with prostate cancer, I think of it as we're kind of behind when it comes to thinking about genetic testing in this space versus some of these other cancers. So we still have a lot of catching up to do. So just because there's not clearly defined information for all of these genes doesn't mean that I'm not talking to my patients about what the testing would look like and what the options are, because this information can be really important for other at-risk relatives as well as treatment options. So why actually undergo genetic testing? What were some of the components that we would think about for this? So for my patients, these are things that I talk about with them, in that this potentially can help explain a cancer history, either personal or family history. And that I see some patients and they're like, there's all this cancer in my family and, you know, I don't really understand why this is happening. We potentially could get some more information about that. But because these cancer or hereditary cancer genes are not only associated with prostate cancer, there can be risk for other cancers. this can help us inform whether or not there's other risks for a patient that we need to be on the lookout for, and actually implement increased screening to make sure that we're managing those cancer risks. But then there is possible information for informing treatment options. And then if there's a positive result identified for somebody or one of these genetic mutations, this can help lead to testing for other family members to help determine if they're at increased risk and whether or not we need to be doing increased screening for them. Because if somebody tests negative for a gene mutation that was identified in the family, then we know that we potentially could bring them back down to general population risk. But, with everything, there's always going to be limitations. It's not going to provide an answer for everything. So I typically get a lot of questions about whether or not this would give us information about prognosis or possibility of recurrence or kind of aggressiveness of disease. And that really isn't answering, this testing really isn't answering that question. It's really saying, was there a genetic change that you were born with that could have predisposed you to develop this prostate cancer, and doesn't really tell us anything about the specifics of your prostate cancer. There's always the possibility that something like this can lead to increased anxiety or guilt. Sometimes I meet with patients and they're still, pretty early on in their diagnostic journey, if you will. And maybe this is one piece of information that's a little bit too much for them right now. They're already, they're still processing the fact that they have a diagnosis and are trying to deal with, making decisions about treatment. And this is just not something that they want to think about at this point in time. There is a possibility of getting uncertain results back. And so this leaves patients in a little bit of a gray space when it comes to what are we going to do with this information? Is it actually helpful that we know this now? Because we don't really know what to do with it necessarily. And then there's concerns that come up for genetic discrimination, which is something I'm going to touch on a little bit later. But this is also a factor that goes into decision-making for whether or not somebody wants to undergo genetic testing. And then really the ultimate goal of doing genetic testing is that, we're not only identifying information for that individual, but this is something that's potentially going to affect the whole family. So if we can actually test other family members who are unaffected, and if they're at increased risk, we can initiate increased cancer screening to either prevent a cancer from happening or identify it earlier when it's more treatable. So this can have really big impacts for families if we do find something with the testing. And then to get to some of those implications for treatment. So one of the latest and kind of hottest things on the scene when it comes to treatment is something called PARP inhibitors. So for individuals that have changes or mutations in these DNA damage repair genes, such as BRCA2 or some of those other DNA damage repair genes that we talked about, we've found that they might respond better to certain targeted treatments. And one thing that I do want to say, because I want to make sure that it's clear, is that this can be applicable from a germline perspective. So if we do testing and identify a change that you were born with, but it also can be applicable when we're talking about the tumor. So do you have something that only occurred in the tumor that you weren't necessarily born with that could have implications for treatment? So both of those are actually relevant when it comes to thinking about things like PARP inhibitors. But the way that this works is that you already have impairment in one branch of repair pathways for when it comes to maintaining and repairing DNA. So PARP inhibitors actually work to shut down an alternative pathway when it comes to being able to repair DNA. So we're kind of stopping, we already have this inherent blockage in that system because of a mutation in one of these genes. And by shutting down the other side of things, this ultimately could be leading to death of these cancer cells because they don't have an alternative way then to repair DNA. But I do always like to mention that this is still pretty new. It's been tested in other cancers, things like ovarian cancer is kind of where it got some of its legs, but it's not a first-line therapy option when it comes to prostate cancer. So there's still other treatment options that we know are effective that individuals would need to have tried before we would think about initiating PARP inhibitors. And this is definitely a conversation to have with your provider or with your oncologist, because they're going to be the ones making the decision about what to do with this information. But it gives us more information if we have, if we know that there's one of these mutations that's present. Then in addition to PARP inhibitors, there's also things like immunotherapy now. So I mentioned Lynch syndrome earlier. Individuals with mutations in things like the mismatch repair genes might respond better to this kind of alternative treatment. And once again, it's still not a first-line therapy option, but it's something that can be considered if other therapies have failed. So I think this really, and this is really only within the past like 1 to 2 years that this has really come out. And so I think this is only the beginning of what we're going to see with some of these more targeted treatment options for individuals when it comes to the genetic side of things. And to come back to this concept of genetic discrimination. So I always like to mention that there is a federal law called the Genetic Information Non-Discrimination Act, or GINA. Most people don't know about this law because it never comes up outside of the context of actually doing genetic testing. So for this, it's a federal law that was passed back in 2008. It's completely separate from the Affordable Care Act, so it's its own standalone law. And the two major provisions that we have is that health insurance companies can't use this information against you when it comes to your policy, and employers cannot use this information against you when it comes to making decisions about hiring or firing. There are some notable exceptions, things like life insurance, long-term care insurance, and disability. One of the things that I sometimes will talk extensively to my patients about is that it's not the situation that somebody has had genetic testing and that's it. They're not going to be able to get an insurance policy. There's a lot of different factors that can go into this. But if it's the situation that somebody is on the fence about wanting to initiate one of these policies, I would always recommend that get set up with that policy, and then we can revisit doing genetic testing, because once you have that contract with that insurance company, they can't take that away from you, even if you've had genetic testing done. And I included a link here for more information if anybody is interested in looking more into GINA, because there are some other specific details about it, but these are kind of the major points. And so how does this actually work? How do we actually go about doing this testing? So it can be performed on DNA that we get from a blood sample. It can also be on DNA that we get from a cheek swab or like a buccal sample. And then we can also do saliva testing. The testing is really kind of conducted by reading through all of our genes to actually determine, are there any spelling errors? Are there any substitutions or alterations that are happening in the known sequence of this gene? Or is it possible that there's missing information or extra information that's present in that gene that's causing it to not work properly? The testing usually takes, I always quote, usually about 3 to 4 weeks. So it's not something that's rapid testing, if you will. And then I did want to make a note that insurance coverage can be highly variable when it comes to genetic testing. But there are the out of pocket that can be seen with insurance is usually going to be based on your deductible. But because of this variability for insurance coverage, because of the variability when it comes to deductibles that individuals might have, many labs are now offering things like patient pay prices. So we're actually not going through insurance at all, and you're paying a fixed price of $250 or less. So there's this misconception out there that genetic testing costs thousands of dollars. It certainly used to a number of years ago, especially when we were first starting up with testing, but the prices have come down significantly, and it's much more affordable and accessible to people now than it was previously. And also wanted to note, since this kind of came up a little bit earlier in the presentation, is that the testing that I'm talking about is addressing the germline side of things, so something that you were born with. But there is also testing that can be done on the tumor that serves very different purposes than what we would be doing for this germline testing. So often the goal is to get a better understanding of the genetic profile of the tumor to help get information about either therapeutic targets or to get that information about prognosis. What do we think the likelihood of recurrence is based on what we're seeing for the tumor? What is the likelihood of things like metastatic disease, about treatment decision-making? So do we want to do something like active surveillance, or do we need to do definitive treatment for a patient? So that idea of, getting a better idea of what is going on with your tumor itself and what the prognosis and specifics are for that is where the tumor testing comes into play, and not something that necessarily is coming from the germline side of things. And I just included some examples of testing here. It's possible that you could have come across this for one of your providers. And so this is just kind of a schematic as well as where these can kind of come into play. So we have two components when we're thinking about treatment implications, is the germline side of things and potentially the tumor side of things. And then also wanted to add this in here because this is also a conversation that comes up frequently, is this what I like to refer to as recreational genetic testing. So things like Ancestry or things like 23andMe. These are really easy to access platforms. They tend to be fairly inexpensive, and there can be interesting things that we find out. So we, learn more about our family or learn more about different traits that we might carry. But I always caution my patients for things like this is that this information isn't necessarily clinically actionable. So there might be a number of different risk factors that are identified, but those risk factors aren't necessarily actionable when it comes to making clinical decisions. And especially when we're talking about things like hereditary cancer syndromes, these tests aren't going to address that, with the exception of 23andMe, who does offer very specific testing for the BRCA mutations that are present within the Jewish population. So unless you're Jewish, the likelihood of this testing being informative is really very low. And we're not addressing anything else besides those genes, at least that I'm aware of at this point. So it's not gonna replace what we've been talking about. That kind of testing for these hereditary cancer genes isn't going to be replaced by this type of testing. And there can be a lot of concerns with the accuracy of the data that comes back. So lots of possibilities of false positives or false negatives. And the interpretation of the data can be very difficult, especially because we're not looking at these genes the way that we would be looking at them from a clinically validated standpoint. And so I just also wanted to put a plug in for genetic counseling. And since a lot of people haven't actually had the opportunity to work with a genetic counselor or have never come across them before, I just wanted to give everybody some background on who we are and what we do. So for genetic counselors, we have specialized training in medical genetics as well as psychosocial counseling. There's about 5,000 approaching 5,000 of us that are practicing nationwide. We have to graduate with a master's degree from a program that's accredited or certified for genetic counseling. And then once we pass our program, we actually need to sit for a board exam that's given by ABGC. And we've been talking a lot about cancer genetics and cancer genetic counseling, but there's genetic counselors that exist in a number of different spaces. So things like prenatal, pediatrics, even industry, research, specialty clinics. So we kind of occupy a number of different spaces. And then in terms of the roles that we play from the oncology standpoint, so if somebody is really concerned about their family history, maybe they brought it up to their doctor, maybe their doctor put in a referral for them for genetic counseling. This cancer genetics counseling section here is kind of what we go over with you in a session. So we're going through a 3-generation family history. We're reviewing all of those cancers that we're seeing. We're doing a risk assessment for you. So we're trying to figure out, based on the cancers that we're seeing, what's the likelihood of there being a hereditary cancer syndrome here? Are we suspicious of something? Does it look like the family meets criteria for testing? And should we actually be doing genetic testing? But then we're explaining the cancer syndromes. We're talking through what we're suspicious of with you, the cancer risks, medical management recommendations. But as I alluded to earlier, we're also doing a psychosocial assessment. So maybe now is not the right time for somebody to undergo genetic testing. Even with the implications for treatment, I never think of genetic testing as an emergency situation. There's always time for us to take a step back and figure out when we want to initiate testing. We talk about the possible test results with you, and we facilitate that decision-making process, because ultimately it's going to be up to you as a patient, because this testing is completely voluntary. You're not required to do it. So all of it comes back to how much information you're interested in getting and what's going to be meaningful for you and your family. But then we also talk about other considerations. So getting in the weeds about insurance coverage or the cost of testing, turnaround time, things like that. And then if we do testing, once the testing comes back, so this post-test counseling, we're disclosing those results to you, but we're interpreting them for you. What does this mean for you? What does this mean for your family? But then we're also helping to coordinate follow-up care. So if there is a positive result in the family, we can get you connected with specialists or figure out if there's somebody local that you can work with. And we also help facilitate testing for family members, because we're not just going to give you this test result, we're going to support you and your family in terms of actually getting other people tested if they're interested. And wanted to include here how to actually find a genetic counselor. So our National Society for Genetic Counselors has this Find a Genetic Counselor tool. So I just included a screen grab here. And especially with everything that's happening with COVID, we've had a surge of telehealth that's available. So some genetic counselors are still practicing and seeing patients in person, but a lot of people are now using telehealth, which I think is significantly increasing the access to genetic counselors, because there's only so many of us, and there's a huge unmet need when it comes to genetic testing. So hopefully this telehealth option will persist in the future, even outside of COVID. And so for some conclusions and wrap things up here. So genetic testing with prostate cancer is still new, and it's definitely evolving. We have a number of genes that have been associated with it, but we still have a lot to learn. But I think with what we've talked about today, hopefully you can appreciate that this is still kind of in the early stages, and the genetic testing as it grows and as we learn more is going to continue to be informative when it comes to treatment options, especially as our science gets better and our research continues to expand. And that genetic testing can help explain cancer history and inform risk for cancers, other cancers for you as well as your family members. And then something that's always a plug is that be aware of your family cancer history. Talk to your relatives, find out about information that maybe hasn't come up before, and actually share it with your provider, because this is going to help them figure out whether or not they need to send you over to genetic counseling and think about doing testing. And that genetic counselors are available to help determine if testing is right for you. So that's the whole purpose of our job, is to help support you through this decision-making process and to walk through all of these components with you. And then some resources included for additional information. So BRCA Blue is one of the few organizations that is out there that is more targeted for these hereditary prostate cancer, specifically BRCA, and then prostate cancer markers, and links for both of those sites there. And with that, I will wrap up, and I'm happy to take any questions, and I appreciate everyone taking the time to listen today.
Thank you so much, Brittany. That was so educational, and even I learned stuff, which I always appreciate. So thank you so much for that.
Yeah, of course.
We do have some questions, so I'm gonna start with an easy one.
Okay.
So, what is the family impact of testing positive? How do you know if you need to talk to your loved ones, and how does that work?
So if you're meeting with a genetic counselor, one of the things that all of us as genetic counselors should be doing, and what I also do for my patients, is provide something that's called a family letter. So if there's a positive test result, sometimes it can be really hard to figure out how to approach the subject of discussing this with them. And so with this family letter, it includes a kind of bird's eye view of what's been identified in the family, what's the gene, what are the cancers associated with this gene, and information about how to find a genetic counselor in that family member's area. So it's a way to kind of introduce this information to a family member, give them all the information that they need about how to find somebody to get set up with testing. And it can be a way to kind of start off the conversation. So even if you send it by mail, send it by email, or talk to them over the phone about it, it's a way to kind of start that conversation.
That's wonderful. So we had a question we understand that the cost of the genetic testing is actually becoming very reasonable. How about the services of genetic counselors? Are your services covered by insurance companies?
That's a great question. So typically for most insurance companies, it is a service that's covered. Typically it's treated more as like a specialty appointment visit. So if you go to see like a dermatologist and you have a copay for like that type of specialty visit, it can get a little bit tricky for certain insurance companies. They might, especially when we're talking about things like Medicare or Medicaid, genetic counselors are not actually recognized providers by CMS, which a plug that there is a law in place that's hoping to change that, or a bill in place that's hoping to change that. But some genetic counselors will work with physicians to see patients that have things like Medicare or Medicaid. So there's ways that we work around this, but this is typically something that would be covered by insurance.
Perfect. Thank you. So there's a couple of questions, and I'm not sure if it's within your realm to answer them, but the first one is, what is your opinion on the recommendation for genetic testing for men diagnosed with prostate cancer before the age of 65?
So I think, kind of as I alluded to a little bit in my kind of highlights of what we are looking for signs of hereditary syndromes, certainly earlier ages of diagnosis is going to be suspicious. But if I see somebody that comes in that was diagnosed under the age of 65 or even under the age of 60 that has localized disease, there's not really any other family history, I might not necessarily feel super strongly about doing genetic testing because it's possible that there would be a low likelihood of identifying something. But that's why we still review that family history, because there can be components in there that help sway that risk assessment one way or another in terms of whether or not somebody's going to be meeting criteria for testing and whether or not we're actually suspicious of there being a positive result in the family.
That's great. And how do you handle it if somebody doesn't know their family history?
Also a great question. So there's always going to be limitations when we're talking about family history. I've worked with people that are adopted or maybe don't know one side of the family, so we don't have any information about those relatives. And so we certainly work with what we have, and we use those limitations to kind of help us figure out, if we don't have this information, should we still be doing testing because we just don't know if there could be something going on that could be influencing the cancer risk for the patient that's in front of us. And so there's a number of different components that go into it, but even if you don't know family history, that doesn't mean that we couldn't think about doing genetic testing.
That's wonderful. And then, have you heard of a genetic correlation between BPH or enlarged prostate and prostate cancer?
That's an interesting question. So because I'm not an MD, I can't really comment on kind of some more of these prostate specific questions just because I'm not treating patients with prostate cancer. Yeah, so I can't really comment on that too much further, but I haven't heard anything, but because I'm not in that space, it's possible that I just haven't come across it.
I haven't heard of anything either, but yeah, thank you.
Yeah.
And then we have two more questions and I'm going to cap it at that because I think we could keep you here for a couple of hours. The next question is, are there clinical trials specific for genetic testing, whether that's with prostate cancer or just independent?
Clinical trials. So clinical trials, I'm assuming probably in the context of treatment, was the question being asked.
I think so.
Yeah, so I know that a lot of the PARP information that's come out recently has been a result of clinical trials that have been going on to kind of study this information. So I'm sure that there's probably going to be more trials that are coming up in the future because there's going to be expansion likely of some of the information regarding that based on that first clinical trial that happened. What I'm referring to is the PROfound study that was more specifically looking at BRCA, ATM, and CHEK2 mutations. And I believe that there was also some other DNA damage repair genes that potentially were included in that study. But I think because there's other genes that potentially could have impact outside of those 4 genes, it's likely that we're going to see more clinical trials kind of starting up over the next year or so.
That's awesome. Okay, and now I have another question, so I'm going to ask you 2 more.
Yeah.
This one is a little complicated, but we talked a lot about the germline mutations or the mutations that you're born with or that you inherit from your parents. You did mention somatic mutations, and one of the questions is, does that change over time? So we know that if you could develop a somatic mutation during the course of your cancer journey, would that change more than once? So and how often should you be tested?
Yeah. So I think there's kind of two questions going on here. So from the germline side of things, the these findings aren't going to change for you because these were something that you were born with. So if somebody has negative testing, that doesn't mean that, a couple of years from now, that result might be different because there's been some time. There might be more genes that are available for testing that we didn't know about when we initially did that testing that we would want to revisit. But that's not going to change. Those were something that you were born with, and they're going to stay the same your whole life. But from the somatic side of things, there are going to be changes that occur in that tumor that change kind of as that tumor is developing and growing. So there can be situations where maybe there's multiple tumor tests that go on for a patient. Maybe they had tumor testing that was performed on their prostatectomy sample. And then maybe if somebody has metastatic disease, there's a biopsy that's done of that metastatic disease site, and then tumor testing or somatic testing that's done on that. So the composition or genetic makeup of your tumor can change over time, but your germline or what you're born with isn't going to change.
That's great. And then the last question is really more of your opinion and the availability of genetic testing in the prostate cancer space.
Mhm.
I know that it's commonly accessible in academic medical centers like yours.
Mhm.
How do you feel that patients can access it, or is it available as widely if they're being treated maybe out in the community or not at a big medical center?
Yeah, so I will say that the changes in the guidelines really were what prompted my position in the urology department here at Northwestern to be developed. And I want to say that it's probably even now still one of the few genetic counseling urology specific positions. Not a lot of genetic counselors are available or practice very specifically within the urology space. I think this is going to be something that changes over time. But I feel really strongly about educating community providers or people that are at private practices about prostate cancer genetic testing, because this has changed. This is a new field. It's constantly evolving. The guidelines, the recommendations are changing, and it can be a lot for these providers to keep up with, especially because they're not providers that are used to thinking about genetic testing for their patients. So I definitely have personally pursued efforts to try and increase that education because there are either independent genetic counseling services that are available. So these are genetic counseling practices that do like telehealth that aren't associated with major academic centers that can help support that need in areas that maybe don't have a genetic counselor. But then for the genetic testing labs, they also employ genetic counselors. So I always try and encourage providers that if they're working with a specific lab, to then utilize the genetic counseling services that are available at that lab to help work with their patients so that they're not trying to find somebody that's in their community if there's someone that's not available.
That's a great recommendation. We often forget that those services, we just think of them as laboratories and don't remember that they have extra services available. So thank you so much for that.
Yeah.
So with that, I want to thank everyone for participating. Brittany, especially you, that was a fantastic talk. We really appreciate your time, and especially at the end of a long day. So thank you so much.
Yeah, thank you, Lindsay. It's really been a pleasure, and I'm happy to have been included in this.
Thank you. And just as a reminder for people who are listening, if you want to listen again or refer this webinar to a friend, you can find it on our website, prostateevents.org. And of course, we want to thank our partners, Clovis, for making this educational webinar available for all of us. So thank you to them as well. And we really appreciate you. Thanks again, Brittany.
All right, thank you. Take care, everyone.
Bye-bye.